there's a very high fibular fracture, and that's associated with a vertical medial malleolus. So we would fix that from the back to confer posterior stability, and a buttress plate, or contour buttress plate on the medial side rather than some screws. I don't think it matters as long as you make sure that you get it anatomically reduced and confer good stability. So there's your classic straightforward lateral malleolar fracture fixed with an interfragmentary screw and a 1/3 tubular plate. That's the stock and trade of everyone in this room, I would think. But in a bimalleolar ankle fracture, I would suggest to you that the teaching that we used to have, which is to put a plate on the lateral side, then fix the medial side, isn't always right. Okay, so think sometimes it's better to fix the medial side first, because once you fix the lateral side, sometimes the medial side is displaced and difficult to reduce. Whereas you've got big bony fragments on the lateral side, it's sometimes better, whilst the patient's not got a sandbag in, to approach the medial side, get anatomical reduction on the medial side, close it up, get a sandbag, and then approach the lateral side and get that reduced and fixed with a plate and some screws. Don't put your brain in the fridge, okay? So in other words, think carefully as you do this. Don't switch onto autopilot and just do the same thing every single time. What about syndesmotic injuries? We're going to hear a little bit more about them. I'll just very briefly say that these can be really tricky. They can be very unstable. And remember that fixing the fibula doesn't necessarily confer stability on the syndesmosis. Sometimes it's the medial side which can confirm stability. Be aware of those anterior collicular fractures that we were just talking about. I think you should always screen your fixations in syndesmotic injuries, and you should because of high fibular fractures, because you've got to make sure that the fibula is out to length. A short fibula will lead to ankle arthritis very quickly, because the talus translates laterally, and cartilage we know does really badly if you shear it. So if your talus is unstable laterally because your fibula is short, you're dooming that patient to early post-traumatic arthritis. So make sure you restore the length of the fibula. Even if you've got a mesonerve type injury with a high fibular fracture and a syndesmotic injury, screen it so that you get the length right. I won't talk about that because others are. What about this posterior malleolus? I think Mark mentioned this a little bit, and others will again, and I think you'll find this is a common theme throughout the day of trauma, that there are some injury patterns which have been ignored historically, which are actually really, really important. Posterior malleolus is really important. Why shouldn't it be? We've always focused on the fibula and the medial malleolus. We sort of ignore the posterior malleolus, and that's not wise. It's at least as important, and in many ways more important than either of the other two malleoli, because this is part of the major weight-bearing surface of your ankle joint. 20% of posterior malleolar fractures are actually transverse in orientation, and you have to be very careful, and you will only see those if you CT scan your patients. Forget this notion of it being a quarter of the articular surface, and that if it's more than a quarter you fix it, and if it's less than a quarter you don't. That's putting your brain in the fridge, right? Think about what that posterior malleolus is conferring in terms of stability. Think about your injury pattern. Is the posterior malleolus important because the posterior inferior tibiofibular ligament has gone with this injury? And if that is the case, it needs to be stabilized. So I would strongly recommend, if you have it, to think about using CT. No one would argue that that needs fixing. We fix them from the back. As Mark said before, the skin on the posterior lateral aspect of the ankle is very, very forgiving. So even though you may have blisters on the medial side and you're fretting and worrying about the soft tissue element of the ankle, which you should do, you can fix them from the back sometimes in nice soft tissue that heals well. As Mark pointed out before, and he's published on this, that the posterior approach to the ankle is exactly the same, really, as Henry's approach to the wrist, which you all learn as junior registrars. It is no more frightening than that. So it looks like that. You've seen that slide already. There's your little apex point. So when you're fixing these, that little apex there is the bit that you need to snug in. It's exactly like your volar Barton's fractures in the distal radius. It's a shell with often a significant piece of cancellous bone deep to it, and you can tuck that apex in and you can buttress it down, just like you do in a distal radius fracture. What about the little fragments? Well, like I've said, those little fragments can still be very important because that little fragment carries the posterior tibiofibular ligament. So we still treat them for their instability, and we still fix them even though you may look at that and say, well, that's crazy, that's less than that 1/4 that someone told me about 20 years ago, which has absolutely no evidence behind it whatsoever. What about some special cases then? So what about ankle fractures in the elderly? Our population are getting older, and this, certainly in the UK, and I suspect for you guys, this is a boom industry. Your patients are getting older. So think about their soft tissues, because their soft tissues are much less forgiving than the younger, sporty chap who may have come off his moped. So think about their subcutaneous tissues and the effect of the injury on these, and think about timing your surgery. Like we said before, think about bridging fixators to allow the soft tissues to settle. Perhaps, if you're smart enough, think about using percutaneous fixation techniques with plates. You've really got to know about your anatomy before you start slipping plates through small holes. So that's the next stage, perhaps, for people. Think about what things you can make better in that patient. So can you improve things in them? Can you look at improving their oxygen carrying capacity because they've got chronic airways disease by putting some low flow oxygen on them? Can you give them some protein, improve their diet? So whilst their X-fix is on and they're waiting for a week, can you fatten up the calf, so to speak, and improve their renal function? What about the way you're actually going to fix them? Well, the standard fixation may have to go in the bucket because these patients are often rather different. They've got a different injury pattern. So think about doubling your fixation. Think about using plates and screws and wires. Think about using locking plates. Think about bolting the fibula to the tibia so that you're conferring stability, what we call tibia-profibular fixation. Maybe you guys are probably more experienced. I don't put Ilazarovs on, though my hospital puts hundreds of them on. Think about using frames to support these patients. So your standard fixation, which you can see on the screen here, in this fracture, failed. And it failed because the bone quality was too poor to be just fixed with a standard DCP plate and 3 distal screws in that fracture. This lady's bone fell off her plate, essentially, and so she needed something more doing. Because of that translation of the talus under the mortise, she gets rapid arthritis, which is what happened here, and she ended up needing a much more definitive form of fixation like an intramedullary nail. And that might look draconian, as Mark said before, to have an intramedullary nail right across the ankle, but you might be saving this lady's leg because these are out through the skin. So as this translates, that medial fixation is penetrating the skin. She's going to get deep sepsis. If you leave her like that, her soft tissues will fail. She will lose her limb. We use quite a lot of tibia-profibular fixation because the tibia's got lots of hard, strong bone in it, and you can pick up 3 or 4 cortices with your screws, gives you a great deal of stability. Yeah, you may limit ankle joint dorsiflexion by bolting the fibula to the tibia because obviously normally when you dorsiflex your ankle, your fibula externally rotates. But we don't mind that because we're trying to get this fracture to heal, and if that is the case, you can take those screws out down the line if you need to. Think about locking plates. Now, the evidence behind locking plates is controversial. They're more expensive. The companies like us to use them because they're more expensive. Theoretically, they're more rigid. One of their advantages is that you can angle your screws in different directions and lock them into the plate if you've got a multi-directional locking fixation, and you end up with something that's very, very strong. And we know that the evidence behind that is good. Sometimes you can combine them, so you can use a locking plate and tibio-profibular screws. This isn't going anywhere. This is going to stay and it's going to heal. And we use nails in situations like this. And Bill Harris, who's one of the BOFAS guys, has published this as a short group showing good outcomes in frail elderly people. The Israelis have published a larger series of fracture fixation with intramedullary nails. They've done very well. About 1 in 5 needs to be removed down the track because the patient recovers function, and the limitation in motion that the nails cause is a problem for them. And patients tend to drop 1 stage in their mobility. So if they come as an ambulant patient, they'll often end up needing to use a stick if you do this. If they come in using a stick, they may subsequently need to use a pair of crutches after this. So what about another special group of diabetics? These are a massive, massive tsunami of patients that are going to hit us over the next 10 years, and we need to really focus on these as a very special group of patients with ankle fractures. A third of patients with ankle fractures in diabetes have major complications when compared with a non-diabetic group, and 1 in 10 of them end up with a transtibial amputation. And if you amputate the limb in a diabetic, their survivorship beyond 5 years is less good than if they've got lung cancer. So watch for the other issues that diabetes have. Watch for Charcot, watch for vascular compromise, and these patients are very, very prone to infection. Even if you watch for all of these, you've still got patients with a high failure rate of fixation. We extend our treatment in diabetic patients, so we tend to double the period of time that we keep patients immobile. So if you would normally immobilize an ankle fracture for 6 weeks, non-weight bearing in a diabetic, make it 12 weeks. It's a good, safe way of thinking about things. Think about a more prolonged period of perioperative antibiotics, and think about stabilizing them twice. Use your locking plate with profibular screws. Use a locking plate and supplemental screws and wires. Bury your wires in diabetics, but really go to town on these patients. They need really good structural stability. So here's an example, type 1 diabetic in a relatively young man, I think, with a neuropathy, with a fairly standard Weber B fracture, but there's some medial clear space there, so you're going to think about doing something to him. We would use a locking plate and profibular screws, even in him. He's got a neuropathy, and as such, he's very, very prone to not feel this as it starts to give way. He's very likely to not be compliant. Patients with a neuropathy, their brains don't function as well as patients without neuropathy. They don't understand instructions. They will walk on their plasters when they're instructed not to. You have to keep that patient safe. One of my colleagues in Sheffield says that paranoia is a healthy thing. What he means is that if you're fretting and worrying, thinking it's all going to go wrong, that's not a bad thing for you to be thinking in those terms. Insist on them being non-weight bearing. Check their soft tissues regularly. Treat them as any other individual, but think of the complications that this patient's at risk of. So in terms of ankle fractures in general, be careful taking your history, be careful examining your patient. Know about the soft tissues before you have that patient in an operating theatre. If you've got an unstable fracture pattern, temporise them with an external fixator whilst the soft tissues settle. If the patients are blistered, it's a very good way of making sure that you can observe those blisters improving so that you can operate on them at a safe time. Foot and ankle trauma is a real problem if you operate on it too early. You'll hear us talk about calcaneal fractures and talus fractures and all sorts of fractures, and you'll be tempted to go away and fix them early. Please, please don't. Make sure that the soft tissues are right. Otherwise, you'll do fantastic fixation and you'll be cleaning your wounds with metal polish because you'll be looking at your screws and your plates. That's not good. So let the soft tissues guide your management in terms of timing. Know your anatomy and the biomechanics. Think about using some stress x-rays so that you can differentiate stable from unstable ankle fractures. Complications are large, but if you're very careful and you follow the basic principles that we're talking about here, you'll avoid most of these issues. So in summary, we've talked about the anatomy, a bit about the classification, differentiating different fracture types. Think about your elderly and your diabetics as special cases. That's not just an old woman with an ankle fracture, that's an ankle fracture in an elderly patient at risk of losing their limb. Key points: careful clinical and x-ray assessment. Think about stability. Please, please, please manage the soft tissues. Reduce them perfectly. Nothing else will do. Thank you.
Thanks, Chris. Fantastic talk on ankle fractures. I'm going to throw in a bit of a controversy and also make it into a bit of an interactive session with faculty being put on the spot for some of the things that Chris has covered in his talk, and I'm just sort of raising some controversies in literature about it, and then try and see if we can have a sensible way of thinking and making a plan for our patients. So may I invite Mr. Hariharan and Mark Davis and Dr. Shah, if he's still here. He'll be here in a minute. He's just gone to make a quick phone call. Is it working? What we're going to do is look at some of the aspects of ankle fracture management, right from timing of it, when do you do it, to right down to rehabilitation. So we're going to go through a pathway that we normally go through in our ankle fracture management. Okay, so what are the controversies? Controversies are about swelling and timing on surgery, and does it have a bearing on the outcome, and what does the literature say about, and what do we think as foot and ankle surgeons? What do you do with blisters? That's common, isn't it? With your ankle fractures, you will have the high energy one will always get some blisters. How many of those get blisters? How do you deal with them? You know, so we'll talk about that. Chris has already touched upon this very important subject. Is it stable or unstable? You've got to be clear in your mind. Are there potentially unstable fractures that you should be thinking about. And then syndesmotic fixation. Time and time again it comes up with which device is better. You use bioabsorbable, you use tight rope, you use syndesmotic screws. When do you take them out? Is it necessary to take them out? And if you leave them in, what is going to happen? Posterior malleolar fracture, I can't agree with Chris any more than what he says. I can't agree with him more, really, on this. I think we need to be much more aggressive with our posterior malleolar fractures, and we look at the controversy around fixation of posterior malleolar fractures. And rehabilitation, looking at, are we happy doing 6 weeks of cast, or is it time to move on to something more functional? The whole world is moving towards early movement, early rehabilitation. The ankle fractures are no different. And specials, just to take home, a couple of take-home messages, which I think Chris has already covered. I'll just touch on those. And I think they are really, really important. So, the first thing, when I went to the UK, I worked with a boss who said, oh, this ankle is too swollen. Let's come back tomorrow, have a look at the swelling. Then we went back tomorrow, he said, oh, still very swollen. So we'll do it next day. We went there for about 4 days in a row, and it was in a plaster, almost out of equinus, and I'm sure it was subluxed as well, which we never took an X-ray for. And then the next job was a guy I worked with, a trauma guy, said, come on, there's no ankle fracture that you can't fix. Swelling is not a contraindication. You've got to just get on and do it. So that confused the hell out of me. So I thought, okay, well, let's think about it more rationally. So timing of surgery. Chris, you already touched upon your scan, plan. Does it apply to ankle fractures or does it apply to pilon fractures? And is there a distinction between the two in your mind?
Is that working?
I
think that the notion of pilon fractures is broadly brought out because we think of pilon fractures as being, in general terms, a higher energy injury, and we think of ankle fractures as being a simple injury. So, in my mind, it depends very much on the energy that's been imparted that's caused the injury. So, someone who's just stumbled off their high-heeled shoes or slipped off a curb edge, low energy injury with not too much swelling, I think you're okay. If you've got a high energy injury with comminution and instability and soft tissue swelling, then that's exactly the same as a pilon fracture. And I can't see why there should be something special about a pilon that doesn't occur to the ankle. It's about the envelope of soft tissue. The reason a femur fracture, which is obviously always a high energy, well, usually a high energy injury, doesn't cause the problem, is because you've got so much soft tissue around. You've got the muscle bringing in the blood flow, and you've got 2 or 3 inches between your femur and your wound. Whereas in the pilon there's a problem because you don't have, and the ankle is just the same, and so is a navicular fracture or a Lisfranc fracture. They're not well covered by soft tissues. That's the issue, I think.
Okay, great. That's fantastic. I mean, that's a very good way of thinking about it, isn't it? It's your soft tissue envelope outside of your bone. I'm going to throw in a bit more controversy. Yeah. It's coming.
Sorry.
Yeah.
I also think that there's a distinction between the swelling you see in the first 12 hours after an ankle fracture and the swelling that you see 48 hours later. A lot of the swelling in the initial phase of an ankle fracture is often fracture hematoma to a certain extent, but a lot of it is also intra-articular bleeding. There's a big hematoma sitting in the joint, and actually by getting in there very early, say 6 hours or 8 hours from injury, you can effect a good closure by emptying the hematoma.
Harry, that's an excellent point. And the next slide now I've got is evidence. Okay, so this is hot off the press. The top, the first one is a systematic review where they've got a case series of 60 patients of their own, looked at less than 24 hours versus more than 24 hours fixation. And in that first 24 hours, the infection rate was very, very low. Whereas as they went along, their infection rate got worse and worse. So I think there is a merit in thinking in those terms as well, that if you get somebody who's come in and you can operate within next sort of 8 hours, get on and do it. As long as the soft tissue envelope is not completely disrupted, you're not dealing with a multi-trauma patient. So I think definitive fixation in that case is justifiable. Mark, you want to say something?
I think the other consideration about violence and energy to injury is very much dependent on the general health of the organism. In other words, a multifragmentary fracture in someone who's 20 is deemed a high energy injury. A multifragmentary ankle fracture in someone who is 90 is deemed a low energy injury, but the biology is effectively the same thing. Those soft tissues are going to be damaged. There's been crushing of the fracture fragments, and that's another thing to bear in mind. So the soft tissue envelope will behave very differently in the elderly, and that would be my only addendum to the division of these fractures into high energy and low energy fractures.
That's brilliant. Thank you very much. And this is just the same paper I quoted, and I think we've got two things here, essentially thinking about timing of surgery. Can we intervene very early, and are the soft tissues reasonably okay to go in the first sort of few hours? If not, if you've gone beyond, or if you're going to go beyond 24 hours because your soft tissues are not great, I agree with Chris completely. You've got to scan if you have to for ankle fracture, and then you plan and you do your definitive fixation. There is no rush to do it on day 3. There is absolutely no rush. You've got to then watch, make sure your ankle fractures, soft tissues are all settled. Amit, you want to say something?
I just want to ask a point.
Amit, do you want to use the...
You got to use mic, please.
If you are operating on an acute ankle fracture, you are using the tourniquet. Sometimes I notice that I fix the fibula first, and I've come to the medial side. Before, without realizing, I release the tourniquet, and when I go on the lateral side, it is too swollen to close. So I don't know whether the faculty would suggest that we keep the tourniquet on till everything is closed.
Yeah. Dr. Shah, do you want to take that?
See, by and large, I do not use tourniquet for fixing ankle.
I wish I didn't, because I do. But whenever I've had a problem with the tourniquet and I release it, I always think to myself, actually, you know, that wasn't so bad without the tourniquet. Maybe next time I won't use a tourniquet. And then my brain is in the fridge and the tourniquet goes on and it gets inflated again next time round. So I actually think that's a really nice idea, would be not to use the tourniquet. I think the other thing is that I tend to, when I've fixed my lateral side, I close my wound and I then go to the medial side. The reason you may be having difficulties is because you're manipulating things around and re-injuring the soft tissues. I would tend to, each time I fix one bit, I tend to close my wound and then go to the next bit so that I know that I've got my wound closed. That's a horrible situation to end up in. I think the other thing that we haven't mentioned is the idea of staged fixation. So that's something that I think maybe coming about. I've done it once or twice. I know you've done it once or twice too, Mark, whereby you've got all 3 malleoli have gone, the medial and the lateral and the posterior side, but you can either put an X-fix on that injury to allow that patient to be stable and know that the talus is under the mortise, and I think that's terribly safe. You won't go far wrong with putting a simple external fixator on. The alternative would be to go through one of the zones of injury which isn't blistered and problematic, and for us that would be your posterior lateral approach. And then so you put a plate on the posterior lateral side, you fix that posterior malleolus, then the talus is in the mortise. If the medial side is still blistered and swollen, then you leave it for a while and you can then come back in 5 days, 7 days, go back through relatively healthy skin and fix it then. And if that skin doesn't settle and it doesn't settle and it doesn't settle, well then you were wise not to have ever gone in, because all you're going to end up doing is having a wound breakdown. So you can stage your fixation as long as your patient's anaesthetically fit. I don't think that's a bad idea.
No, that's great. That leads us to
how much do faculties on the dais rely on to wrinkle sign before fixing the ankle fracture? Because I feel it applies same for pilon, calcaneus as well as ankle and midfoot. If you see the wrinkles, that's the surest sign to go in.
Go on, Harry.
I have a slightly differing view from you, Dr. Shah, because, as I said earlier, I try and get in there as quickly as I can. But if I have missed that window of opportunity, and it goes on to 24 hours, I would clearly agree that you'll have to wait for the swelling to settle down, because that was the intention of you having delayed your operation.
Yeah.
But in the acute setting, I think I would go in there as quickly as I possibly can, preferably on the same day.
I think in the interest of time, we go on to the next controversy, which has been already touched upon, is blisters. So do you operate when you've got blisters or you don't operate? So this is obviously one of the things that we are faced with as foot and ankle surgeons. About 6% of these fractures will have some kind of blisters. Are they in line of your incision? That is important. Are they hemorrhagic? Because they're going to leave you with more trouble. And there is no real consensus from the literature. So we go back. Mark.
I find blistering very worrying, and what I tend to do is go for an external fixator, and any blisters, for instance non-hemorrhagic blisters, I'm quite happy to, while the patient is fully prepped, aspirate those blisters and dress them. Because the fracture is then stable, you can then remove those dressings and you can watch the soft tissues settle to a tolerable degree over the ensuing days. The worry has always been about hemorrhagic blistering and whether or not that's going to increase the infection rate. And I think it's just going to give us a good slide that answers that question.
So essentially, yeah, thanks Mark. This paper which said you de-roof the blisters and use the dressing, which is what they've used here, silver sulfadiazine. And they had reasonable outcome, but they did say hemorrhagic blisters are a completely different kettle of fish, so you need to recognize those. If they are going to come in your line of incision, definitely scan rather than get on and do your definitive fixation. So I think that's the take-home message from that. Moving on to stable versus unstable fractures. I think Chris has covered pretty much everything that I was going to say. All I can say is this stable? You know, when I was a registrar, happy, stable, you know, looks very stable to me. The more I get old, the more I think about it, the more I think it can be unstable. You know, and that's how you should be looking at it. You should be looking at it carefully. Can it be unstable? Is there anything suggesting that's unstable? So, how to decide? We looked at all this, and we've also looked at, this is Nick Van Dyke's systematic review, essentially suggesting all that what Chris said, all your medial signs that we teach our registrars, everybody, are no good in predicting your stability of the fracture. You have to rely on some kind of stress view, and that stress view is that or that, yeah? So we're going to go back and ask all of the faculty, how many times do you actually physically order a gravity stress view, and how many times do you get it in your own hospital? Because I have a problem with it. So anybody wants to take it?
This is one of those classic situations where I've been caught out because I think it's a great idea. It makes lots of sense. It's evidence-based. It's safe. Do I do it? No, not very often. Because we haven't really set ourselves up to do it as effectively as we should. That's not a reasonable excuse. That's just a failure of our ability to set our system up. I think you should do what we say, not what we do.
One of the things we have done, though, to try and get around it is to ultrasound the questionable cases, and we found that quite useful.
Great. So, yeah, Harry.
Sorry.
Quick one, yeah.
It is, I've done it in situations where I suspected instability, such as whether I was going to distinguish between a supination external rotation type 2 and a type 4.
Yeah.
One of the limiting factors, it's not just the radiographer, but it's also pain.
Yeah.
Even with gravity testing, it is still quite painful.
Yeah. So is that not a reason to go in and then fix that? Because I think that if you put them in the position of taking a gravity view, and you can't get a gravity view because it's so painful for the patient, that's almost certainly because it's unstable, and I'd fix it.
So I take a different stand on this. Whenever I fix up my ankle fractures, I make sure that I would put both the limbs for projection. I would always project the opposite side before ending before doing the closure. And I almost always use this gravity stressed image intensifier view once I feel that I have fixed it up. Yeah, so it's a very good tip, you know. You may not go with the patient in pain pre-operatively, but intraoperatively, before you close it down, do this gravity stress test with your image intensifier in position and compare it, if you are in doubt, with the opposite side.
So you're not using it then to determine whether the ankle's stable, to determine whether it needs fixing?
Yeah.
Because I think that's what we're talking about here to a certain extent. They're the same view, but for different reasons, aren't they? So I'm talking about doing it to decide, is this a fracture that you can treat in a cast and let that patient walk, or is this a patient who needs their fibula fixing? Whereas you're using them to say, is my fixation adequate?
Yeah.
Yeah.
I think one of the other points on the same line is, okay, your gravity stress test comes positive, your X-ray looks suspicious, do you really have to fix it? And then somebody's looked at it as well.
Yep.
And if you look at it, they looked at MRI scans of those, and certainly I don't have the luxury of doing MRI scans for my ankle fractures. But if your deltoid is not completely gone, then you can get away with treating them non-operatively, but you've got to be very, very vigilant. So I think if I'm thinking it's unstable, I'm going to fix it.
Yep.
Okay? So, moving on to the syndesmotic injuries. There isn't any more controversy at all in syndesmotic injuries, is it? Really? We know they are very common. We know they're difficult to treat. We know the outcome gets pretty bad with syndesmotic injuries. There is increasing awareness for these syndesmotic injuries to be present in lower fibular fractures, what we call as Weber B type fractures. So Weber C, we all know, syndesmosis goes. But Weber B type fractures can have syndesmotic injuries, and I think that's one of the other take-home messages from this. So I'm going to just look at to fix it or not to fix it. These are, biomechanical concepts. If you will stabilize both sides, your syndesmosis in theory should be fine, hence you don't need to fix it. And I completely disagree with that, because we all know the syndesmosis can still be disrupted. We're not going to go in detail of that because this is all being covered in the previous talks. However, what I would like to draw your attention to is the malreduction. So in spite of being very careful on table, you're looking at everything, you can have 30 degrees of malreduction in external rotation without realizing. So be very, very vigilant when you're actually looking at that. Here's a case example. Somebody, RTA, where motorcyclist came off, ankle fracture, ipsilateral Lisfranc for good measure. Taken to theatre in emergency, ankle was fixed and Lisfranc provisionally stabilized, was too swollen to do a definitive fixation. What do we think of the ankle? Is it nicely reduced and happy? Doesn't look too bad, does it? We all agree? Dr. Rana, you're thinking about it.
Isn't the fibula short, isn't it?
Yeah, fibula is a bit short, and I was looking through the scans for the Lisfranc fixation because it was on my list, and I found a piece in there sitting nicely, and if I look back now, with the hindsight, it looks like there was something there. So when I fixed the Lisfranc, I removed that piece, and I agree fibula wasn't completely out to length either. So how to assess syndesmotic stability intraoperatively, and that's one of the things that, time and time again comes up. You put a hook and you pull it. Which direction do you pull it in? Do you do your external rotation manually and then have a look? Are you going to see in the AP view, or are you going to see in the lateral view? And I think those are really important concepts to understand intraoperatively to get your fixation that you've done to make sure your syndesmosis is stabilized. So we're going to have another bit of chat. Right. So which direction, Mark, do you pull your syndesmosis and why?
I don't use any of the tests. I use a fluoroscopic stress examination because how much force do I put through? Never as much as the patient will walk on it. So that's going to be the best way of stressing it. You fixed it. If you can't stress your fixation, then you shouldn't be leaving the operation room.
Right, and if other faculty or delegates have a different view on it?
I think you can grasp your fibula between your thumb and your finger and move it backward and forward. And if you do that in next time you do a bunion operation, whilst the patient's anaesthetized, try moving the fibula backward and forward in the sulcus, and you'll find you can't, because you can't in an anaesthetized patient do that because it's held by the A and P ITFL ligaments. And so if you just grasp it and somebody's had an ankle injury and you can move it forward or backward, it's unstable.
Yeah.
And I think that's probably very sensitive. And I do what Mark does, externally rotate them as hard as I can with a mortise view, which I suspect is what you do. And if it moves, you fix it.
Okay, so syndesmotic assessment intra-op is very important, and there are more than one ways to do it, as we learned. But again, you have to look at very carefully, making sure if you're getting too much mobility, as Chris is saying, clearly that's abnormal. It's not sitting in the incesura as it should do because there is disruption of the ligaments there. Okay, so moving on to how to fix it.
Sorry, can I just go back one thing?
Chris,
So one thing, the other thing is the plane of fixation of a syndesmotic injury. So the orientation of your screws or your tightrope or whatever it is you're using needs to be in the intermalleolar axis. So if you put your finger on the medial malleolus and your finger on the lateral malleolus, that's the plane of fixation. And as a tip, when you put the patient's sandbag in, if you've done your lateral fixation, and on your x-ray you've got a mortise view, in other words the patient's internally rotated around 30 degrees, your fixation should be horizontal to the ground. Because most people's tibial torsion is about 30 degrees. What you mustn't do is try and screw that fibula too posteriorly or too anteriorly, because if they're unstable in the AP plane, then you can fix it so that on your x-ray it looks great because you've closed down that space. But if you did a CT, you'd find the fibula is lying anterior in the incisura or posteriorly. So you've got to fix your fibula in the plane of the intermalleolar line.
Great. Harry, you have a comment?
Sorry, I was just going back to your earlier slide. You've put in 3 tests there: intraoperative fluoroscopic stress test, the Hooks test, and the sagittal ballotability test. I think the 3 of them measure slightly different things, and so I tend to do all 3 of them, because the intraop fluoroscopic examination measures the rotational stability of the mortise. And that's basically what it does. So if you had a completely intact medial column, you could theoretically miss out. A Hook test actually tests the integrity of the intraosseous membrane, because you could theoretically say, if you had a completely intact intraosseous membrane, you might struggle to pull the fibula away from the tibia. And the sagittal motion test, which is probably the most sensitive test, will assess whether your fibula is sitting in the incisor or not. So I think it's quite important. You can do all 3 tests. It doesn't take very long.
Okay. Moving on to how to fix it.
Oh, sorry.
Sorry, Chris. I'm aware of the time that I'm taking.
No, I was just saying, I'm sorry, I didn't realize you were just about to talk about this.
Okay, so 1 screw, 2 screws, do you use 3.5s, 4.5s? There's always this controversy. The more you look into the literature, the less answers you get, the more confused you will come out. So we're trying home in some of the take-home messages really, and essentially retain or remove. Right, so once we've fixed it with a 3.5 or 4.5, do you retain your syndesmotic screws, or do they routinely come out? Dr. Shah?
I don't remove it, but I do inform my patient that you might break it. And somebody might point out, don't then point out at me.
Any difference of opinion on that?
So I tend to take them out if I use screws, which I don't often use, but if I use screws I take them out because I think that they usually break. If they don't break because they've limited the motion, and that's bad. If they do break, and that patient continues to have pain, and they probably will, because it was probably a severe injury, they'll probably blame the screw. They may not blame me, but they'll blame the screw, and then some poor soul's going to have to try and remove that screw. And you can take the screw out the fibula, but you can't take the screw out the tibia, and they think that still hurts, and it's all bad because of this screw, which we all know is not right, but if you take it out, I think you've put that to bed.
Okay, well, we'll look at some of the literature published on that. And again, this is a systematic review. And essentially what it shows is, which I tend to do a lot, is if you're seeing them at 3 months, and if you are not getting enough dorsiflexion, they've gone through their recovery, rehab and everything, then those are the candidates I definitely take syndesmosis screw out. Otherwise, I'll have a conversation at that point. You want it out or you don't want it out, and it depends on so I'm not sort of everybody's syndesmosis screw out. I'm more of selective syndesmosis screw out. Okay? So that's another way of looking at it. You are going to see your patients at 3 month stage to see how they've done with your ankle fractures. Okay, so Chris mentioned that. What is going to happen to that screw that you're going to leave in? And this is Vinod Panchpavi's work. And he looked at all of those, and not surprisingly, 3.5s break more number of times than 4.5s will do. Does it lead to any difference in loss or reduction or any change in outcome? It actually doesn't. And he sort of calculated the number, how many numbers you need before you can answer that question of 3.5 versus 4.5. I think we're way off in terms of any studies looking at that at the moment. So which device better? Chris, you mentioned you do more tightropes. Yeah, so we're going to look at tightrope versus syndesmosis. So any advantages from your point of view?
I'm hogging the mic, aren't I? I think the only reason, or there are a number of reasons for the tightrope, I think, being effective. One of them is that, as I was just mentioning before, about positioning the fibula in the incisura. If you run a screw, positioning the fibula in the incisura, the screw will dictate where that fibula goes. If you run a tightrope in, it doesn't, and the fibula will tend to sink into the incisura, even if your tightrope orientation isn't perfect, because it just pulls them together, rather like the intraosseous component of the syndesmotic ligament does first time around, and also I don't need to take them out.
Is it not dependent on the direction you've drilled?
Not so much, I don't think. No.
Okay. All right, so there is a paper out there, obviously comparing the two, and similar outcome. Clinically, it's no different. Lower rate of implant removal with tightropes, obviously, you're going to try and leave them in. But there is that, the high fibular fractures, there is more chance of having a malreduction if you're using tightrope. There is paper out there, which I haven't put it on. So beware of those. And long-term effects of tightropes, we don't know. We've only been using them for some years, a few years now. Cost effectiveness, there is some evidence out there that is almost sort of as cost effective, but there's no randomized trial to control, to answer that question. So outcome, I think this is important, really. Once you see a syndesmotic disruption, this is not going to behave like your normal bimalleolar fracture, which doesn't have a syndesmosis injury. And that's the take-home message. You need to talk to your patient. Your ankle isn't going to last forever. So at some point, you're going to run into trouble, and there is enough evidence in the literature for that, and personal experience of lots of faculty here and delegates. So I think that's the one big take-home for me. I always talk to my patients, tell them your ankle isn't going to do as well as you think, with a normal sort of ankle fracture. So we're going to move on to a different area in the ankle, which is the back of the ankle, posterior malleolar fracture. So we all know the fracture pattern can be variable, and it can be very difficult sometimes. If I get an X-ray like this, I really don't know where the posterior malleolar fracture is in there. Is there one or isn't there one? And even if you get a decent X-ray sometimes, is it your 25%? Size is always a very individual thing, isn't it? Your 25% might not be somebody else's 25%. So you've got to be very careful about that. So we're going to run into a controversy here about CT preoperatively. I think Chris mentioned in his talk CT preoperatively for posterior malleolar fractures. Is it a good thing? Why should we do it? Mark?
We have literally within the last 2 or 3 months started a policy in our hospital of CTing everything that has a posterior malleolar fracture. And there's a very good reason, and it was on the slide that you had before, and that was the bottom line of the slide, which was the CT classification from Yamaguchi. And that is absolutely paramount in planning your ankle fracture fixation. As I mentioned in my talk, it's really important to know where those fracture fragments are, because I may very well do both a posterolateral but a posteromedial approach to fix the fracture line that extends across to the medial side. And quite often the posteromedial and the posterolateral fracture fragments are not joined by a bridge of bone, as you can see in the top right of the slide. They're quite often separate fracture fragments. And by buttressing both of them, you are actually supporting the ankle and giving the ankle stability, such that actually at 2 weeks all you need to do is get the patient into a suitable cast where they can remove it and do ankle range of motion exercises. And for a devastating fracture pattern like this, they have actually a reasonable outcome in my experience.
Yeah, my threshold for doing a CT is getting lower and lower as I'm progressing in my career, and I agree with Mark on, because you think you've got a straightforward posterior malleolar fracture. It determines your approach as well. Where are you going to approach it from? Are you going to go posterolateral? If there's so much comminution on posterolateral side, it gives you an idea and reassurance that you can approach it from the other side, you're going to be fine. So I think it has a bearing on your treatment rather than just sort of quantifying a 25% or a 20% fracture fragment. So I have a lower threshold now as time is going by for doing CT scans preoperatively, and it is a good idea for posterior malleolar fractures.
There was a nice study in the I think it's the British Journal of Bone Surgery this summer where they CT scanned x-rays and looked at what influence it had on patient management by asking a group of orthopedic surgeons with and without the CT whether it would have changed what they did. And the 3 groups that they suggested should be CT'd, and this is what we're now doing, is all patients with posterior malleolar fractures, all patients with syndesmotic injuries, and all patients who have had a history of an ankle joint dislocation, but the first image is a relocated ankle joint in a cast. So that group where the patient says they've had a dislocation, or A&E tell you the patient came in with a dislocated ankle, and the first image you've got plaster all over the place and an ankle that looks like it's reduced. And you think, well, I don't know there, I have no idea how to plan this surgery because I don't really know what's even broken. So CTs and those I think are very useful as well.
Yeah, great. Amit, just quick comment please. Yeah.
Most of the surgeons in India are not aware of posterior medial and posterior lateral approach to the ankle. Especially if you're using posterior lateral approach, I would like to ask the faculty, do they position their patients differently? Most of the patients we operate are in supine position with sandbag underneath the same buttock. But people sitting here, if they have to use a posterior lateral approach, what should they be aware of?
Yeah, that's a really, really good question. Thank you. Most of my ankle fractures I fix with the patient prone, and that allows me to do a posterolateral and a posterior medial approach. It can compromise a straightforward medial malleolar fixation, but if you're ever in the situation where you're operating completely solo, I just close up and then turn the patient over, because you shouldn't ever compromise the fixation. In terms of the posterolateral approach, I have a PDF of the paper that I wrote, and I'm more than happy to disseminate that amongst the audience if they'd like a copy of it. It was written in an instructional journal, so I'm quite happy to give you that. The posterior medial approach is very straightforward. It's just a question of looking after the neurovascular bundle and the tendons as you would ordinarily do if you were respecting the anatomy of your approach. And again, it's just usually buttress fixation.
I do posterolateral in a prone position all the time, as Mark said. And for your medial malleolus fracture, I think I read it in your article and started using it, is you bend the knee 90 degrees, and it becomes so easy. Before that, I used to go sitting down, doing that, aiming up. Now it's sort of bend the knee, and you're actually looking at your medial malleolus. So it's a great technical tip for that.
The simple tip for all those who want to use this approach is you can put a big sandbag underneath the buttock, ipsilateral buttock, and put a lateral post to prevent your patient falling in. Most of us have a table which can be tilted, and so you can tilt the table to the tune of 25 to 30 degree, and 25 to 30 degree you can gain with the big sandbag, and that's how you can go ahead and do it sitting on a table. And then once you are through with that, you can just tilt the table back to the normal position. You can even pull out that sandbag, and you can go ahead with the medial side.
Okay, we're going to move on in the interest of time. So how to fix it? Would you ever fix, Chris said about volar Barton fracture, would you ever fix a volar Barton fracture using a dorsal radial plate? No. So, I think I apply the same principle for posterior malleolar fractures. You would always want to go from the back and fix it. But, here, can you argue, is this a good treatment front to back? Well, I can't see whether there is a bit of a step there. And if I tell you, the more you look at it, the more you see that people have malreduced without realizing, putting a plate on, thinking that's a great idea. So, think about doing it from the way it should be done most of the time. Again, like syndesmotic injuries, if you've got posterior malleolar fractures, again, there's plenty of literature out there supporting that it is not going to behave like your normal bimalleolar ankle fracture. So the prognosis is different, and patients need to understand that. We're going to move on to the rehabilitation, and traditionally, all of us, and I'm sure a lot of us still doing it, is put a 6 weeks cast, non-weight bearing after your fixation, and 6 weeks take it out and mobilize. There is some controversy whether you should be looking at early rehabilitation like everywhere else. It's an intra-articular fracture. Everywhere else we do intra-articular fracture and want to mobilize the next day. Why is ankle different? Is it different? Harry?
No, it's not. Well, that's the simple answer to it. If you've got,
Okay.
stable fixation, I almost never use a plaster. I put them in a boot. I keep them in a boot for 2 weeks and then start gentle range of motion. The exceptions obviously would be highly comminuted fractures, where you needed bone grafting, for example, or porotic fractures. But otherwise, if I've got good syndesmotic stability, good medial stability,
Yeah.
I almost always will put them in a boot.
I want one of the other faculty members to go completely opposite to that if they can, if they have a view on that. Or are you all in agreement? Chris is shaking his head. Right.
And in India also, nobody puts them in 6 weeks of plaster cast. If at all we put in, is for 3 to 4 weeks of plaster slab, and thereafter we mobilize them non-weight bearing. So practically, the
So
cost
when you
part
say
of the
plaster,
good-
just to clarify, plaster slab, are you allowing them to move out of plaster slab, or are you putting a plaster slab and leaving them in for 4 weeks?
3 weeks is the time plaster slab is kept, and then they are mobilized.
Okay, Chris, you want an opposite view, have you, or not?
I wish we could have, I just wish we had consensus on this, and I really don't think we do. And it might be that we don't have consensus because it probably doesn't make much difference. That might be one reason. Or it might be because there's so many variables, people do different things. So my patients aren't, a lot of my patients aren't reliable. Our patients, we have a lot of drug addicts, alcoholics, and those patients, I wouldn't put them in a boot because that boot will be sold and swapped for cans of strong lager, and the patient will walk around on an unsupported ankle fracture. So they go in a cast because they can't take it off. They don't go in a back slab because they can take that off too.
Yeah, I have the same.
They go into a full cast that they can't take off, that's made out of fiberglass.
That's my reason for putting them in a plaster cast as well most of the times. But if I have a young patient and good fixation on table, you come out, there's absolutely no need if they can follow your instructions, what you want them to do. What does the literature say? Well, let's look at some of this is a randomized prospective trial back in 2003, so we're about 10 years down the line, and they suggested that functional outcomes were same or similar at 2 years, and a bit of more risk of wound complications with brace. So it doesn't really support what we want to do, really, does it? So what about this one? This is a systematic review of all the studies, and this is quite recent, 2009. There is that, it is a recurring theme, increased risk of wound complications. So are we allowing them to move with the soft tissues not settle? That is probably my concern.
Yeah,
How do you want to say
that is precisely the reason that I don't let them move for 2 weeks, even in the boot. And I would agree with the point that it's highly patient dependent. If you've got a complete madman or a drug addict, clearly you wouldn't do that.
Okay. Chris has already covered both diabetes and elderly patients, and I think we do need to recognize they're a completely different group. And even in the UK or anywhere you work, you realize somebody treats it as a normal ankle fracture without realizing they're a diabetic with a peripheral neuropathy. They are going to behave completely different. And look at the numbers, from 3% to sort of 43%. That's a massive jump in your complication rate for ankle fractures. So always think of, have they got a vasculopathy or neuropathy with it, and are they going to behave different? And early surgery, if soft tissue allows. Otherwise, reduce and stabilize first. You may need to do an X-fix, but augment your fixation. You're not going to get away with your normal 2 screws on the medial side and a plate semitubular or a 1/3 tubular on the lateral side. You've got to be thinking about making it absolutely rigid. Okay? It's just a case example. When I was a fellow, and I've become more and more aggressive with fixation and also sort of getting it absolutely spot on for their stability. This is the take home. You need to, even if you've got really good stability on table, you still have to think about doubling their immobilization and weight bearing status. Osteoporotic, if you look at the literature, actually it says there is no difference between the two, standard or locking. But we know that most of the locking fixations just come in last couple of years, 3 years, and I have a feeling that as the time goes by, we might see that the trend will be more towards locking plates and better results with that. That's just the literature again for you. So, we come to take home, and I think it is important to just think about some things that are slightly different in your normal ankle fractures, and that's how one should look at it. So it is important to understand basic biomechanics and mechanism of injury, which Chris has nicely covered. Early stabilization is if you get in within 24 hours, fix it if the soft tissue permit. Your infected fixations are going to lead to a very poor outcome. So think about reducing or minimizing the risk of your infection in your ankle fractures. And it is controversial how you assess. As you saw, none of us have one way of doing it, but at least be aware that intraoperatively syndesmosis stressing is important. How you do it, obviously, you got to think about that. If you are having syndesmosis, posterior malleolar fracture, and an ankle fracture, that ankle is not going to behave like a normal ankle. So you need to make your patients aware of that right from the very beginning. An early post-op rehab, yes, it is an option, but you have to be thinking about wound complications, particularly for a bit of a soft tissue envelope that's not looking great. And rigid and prolonged immobilization in patients who've got ankle fractures in diabetics. Harry.
Sorry, can I also add the point which Chris made earlier? Try to get away from the concept of you always got to fix the lateral malleolus first. I think that's a big culture change, and it took a while for us to understand that. But this whole concept, this AO concept, which was propagated by the one paper, Yablon's paper, is that you've always got to pull the fibula out to length. I think it depends entirely on the fracture, and it depends on what you want to stabilize first. So I think that's an important point to take home. Do not be anally retentive on fixing the fibula first every single time.
Thanks very much, and thank you very much, gents.
One last question. After a stable ankle fixation, a standard ankle fixation, is there any harm in getting the patient toe touch weight bearing?
None whatsoever as far as I'm concerned.
So how many of you get your patients non-weight bearing and how many get them going?
All my elderly patients move straight away and walk straight away because they can't manage with crutches and they can't be in bed. And my youngsters, I think it depends very much on the personality of the patient. And some people I'll slow them down, but most people I'm happy for them to touch weight bear.
I keep most of mine actually non-weight bearing for 2 weeks, and that's not because I'm worried about the structural stability of the ankle or my fixation. It's because I want them to elevate the limb to let the swelling settle so that the wound can heal. Yep. And the only way I've really been able to get patients to understand that they're not to let the limb hang down for a long period is if they also understand that they're not to weight bear. So I basically say keep it elevated and don't walk on it for 2 weeks, and then when I see them at 2 weeks and change their cast or put them in a boot, then I know the wound has settled and we're over hurdle number 1, because if the wound doesn't heal, we're in deep trouble.
Great, guys, thank you very much. Next up we've got Dr. Rana, who will be covering pilon fractures, obviously on similar lines but more severe injuries. Dr. Rana.
Thank you, Dr. Jitender, and I thank the organizer, specifically Dr. Jitender, for giving me the opportunity to make this presentation. So it's only me between lunch and you now, so I'll not try to keep it short because a lot of it has been covered by previous speakers, like the soft tissue injuries and the concept of span, scan and fix, which is also a part of concept that we use in fixation and treatment of the pilon fractures. In a doubt in my mind how to pronounce it. We call it pilon, we call it pylon. Better call it pylon because if you don't take good care of your patient, this fracture can really pile on you. If you do not want to have a patient whose leg looks like this, and you don't want to have an angelic smile on a plastic surgeon looking down upon your patient, I personally hate the plastic surgeons when they come in this situation and start to draw maps on your patient's leg. You better be careful about these fractures. If you do not follow the basic principles, if I can start by the reverse, take the basic principles. I'll give you some examples to start the presentation, what can happen. This patient, 25-year male, came to us 7 months after this fixation for a pilon fracture. Fibula stabilized with a plate, some fixation on the medial side and a trans-articular wire. He got infected on the medial side, came to us for a solution 7 months after the injury. We removed the medial hardware because of the infection. There was almost no movement at the ankle. We removed the lateral implants and eventually the patient had to undergo an arthrodesis, which was done by Dr. Rajiv Shah in Vadodara. Did eventually unite, but it led to an arthrodesis, a fusion. So the principle of anatomic articular reduction and tibial alignment with stable fixation has to be critically followed in every pilon fracture like any other intra-articular fracture. Now look at this X-ray, a diabetic patient. We have discussed a lot about this today. It's a diabetic patient with this injury. This was an X-ray which was 7 days post-injury. We've talked about how to fix it. This is a posterior medial fragment. But is it, what do you call it? Did you call it a posterior malleolus fracture, you call it a medial malleolar fracture, or you call it a type B pilon fracture? Whatever it is, it has to be not fixed in this way. It's a diabetic patient. We talk about double the fixation, we talk about double the time of immobilization, and what do you call this? This is, no minimal fixation without immobilization. Sequential X-rays will show how this patient will behave, and eventually came to us in this state for a solution. What do you do to this patient? So, you have to be careful. You have to identify the fracture pattern properly. You have to buttress the unstable side of the fracture, which is most commonly the compression side of the fracture. This is another principle of pilon fracture management. Look at this patient who came to us approximately 7 months after the injury, having had 4 surgeries already done. And this was the earliest X-ray he had in the course of his treatment. A plate had been applied in the pilon fracture, got infected, it was removed. And then this was the second surgery with a spanning X-fix with 2 wires into the